Hello, my name is Eric Salib. I'm one of the sports medicine physicians here at the Sports Medicine Clinic, and today we're going to be reviewing the knee exam. We have a patient here who's going to help volunteer for us, and we're going to look at his right knee today. And we'll go through kind of the whole gamut of how I'd like to do my physical knee exam. Briefly, I start with inspection, move on to palpation, range of motion. We test strength, and then we do special tests. So first we'll start with inspection. So we can see on the patient here, we'll check him both seated, and we'll also check him in the supine or laying position, and we'll also check him in the standing position. Here in the seated position, we're just going to look for any signs of discoloration, any obvious signs of swelling, if there's any bruising or redness in the area. Overall, the knee looks pretty normal in this fashion. We don't see any abnormalities. But while we have him here, we'll just have him do just a simple range of motion, and we'll see how his knee moves in the seated position. So if you could please raise your foot up. I'll bring him an extension, and then we'll let him come the knee back down again. So you can see that he moves the knee very easily up and down in flexion extension. And then from this point forward, I like to have the patient lay down. So if you could. And I'll roll the shorts up a little bit here. And one of the things I always like to do when inspecting the knee is to compare the knee that we're focused on in relation to the other knee or the contralateral knee. So one of the things I look for again will be see if there's any bruising, if there's any redness, which I don't appreciate. Second, we'll look for swelling. When I check for swelling, there's two keys that I look for. One is naturally the patient will have a little dimple on the medial side of the knee, just medial to the patella. That's a normal appearance. If the dimple looks less obvious, that could be a sign of an effusion or swelling inside the joint. And then we'll always compare that appearance over here to the other leg and see if that looks symmetric. In this particular patient, it does not appear that it has any swelling. However, if we want to double check, most of an effusion will sit up in the suprapatellar pouch above the patella in this range right here. So what we'll do is we'll take this area and we'll milk the knee down. So by doing so, we'll just kind of apply a pressure in the distal fashion, trying to move any fluid that's in the suprapatellar pouch to move down into these regions over here, just medial or lateral to the patella. And we'll check for a fluid wave. The way that I like to do that is place both hands on either side of the patella. I push laterally, and then I'll push medially, and I'll see if there's a fluid wave that occurs in the medial aspect of the knee. This particular patient has no effusion, which is a good sign. Next, I'll move on to the portion of the knee around the patella. And what I'll do first are two particular things. I'll again look at the appearance of the patella in relation to how high or low it is, if it's appearing that it's up higher or down lower in relation to the other knee, and it looks symmetric here. And then I'll just kind of gently push around on the patella itself. So one of the simple tests I like to do is something called the Patella Grind. The textbook way to do the Patella Grind would be to take the kneecap, apply a force down on it, moving distally and towards the table here, and I'll have the patient try to fire his quad muscles. So go ahead and try and do that for me. And I'll see if that elicits any pain in the patient. So they'll yelp, scream, cry, or just tell me that it hurts. Second, we'll try and see if the kneecap is stable. We'll take it on either side. I take my index fingers here and I'll pull the kneecap laterally, doing what we call a patellar apprehension test. Again, if the kneecap has had a previous dislocation, is unstable, I'll get more movement laterally, and again I'll test it over on the other knee and see if it is equal. The apprehension test is really meant to see if the patient will have any pain or discomfort. After we do that, now we'll test for palpation. So I'll take the knee, after I push around the kneecap here, and I'll check on the sides of the knee. So the best way I like to do that is flexing the knee up to 90 degrees. And I'll test additional areas of palpation around the patella, medial and lateral. I'll check the distal quad tendon, which is just above the patella. And then I'll come down to the inferior aspect of the patella and I'll find the patellar tendon, and I'll push on the patellar tendon. I'll also come down to its insertion point on the tibial tubercle. I'll push on the tibial tubercle. And then I'll move back up to the joint lines. So the best way to find the joint line, in my opinion, is to follow the kneecap all the way down, and I'll find the very inferior aspect of that patella. Then I will find the fold, skin fold, where the thigh and the lower leg meet. And you can draw an imaginary line, and that's your joint line medially. So you can just palpate and see if the patient has any tenderness along that ridge. You also do the same thing on the lateral side of the knee. Well, again, we'll find the inferior pole of the patella here, skin fold, and this will help us find the joint line all the way across, and we'll just palpate along the lateral joint line. When we palpate on the joint lines, we're looking to see if there's any signs of discomfort related to the meniscus or the cartilage inside the knee. So if someone has osteoarthritis, or if it's more, this is with a meniscus injury, they will usually have tenderness along this area. After palpation, now we'll check his range of motion. In the knee, when he's in the supine position, we'll straighten him back out. We'll see what his flexion arc is. The normal range of motion for a knee would be extension of 5 to 10 degrees, which will be kind of like a hyperextension, and flexion of the knee up to 140 degrees. So we'll test it on him. We'll take the foot, holding the thigh down, and we'll bring him up. And you can see that the patient goes beyond neutral, or beyond zero, of about 5 to 7 degrees. Then we'll take it, and we'll bring his knee all the way back, and see how far his heel can reach towards his butt. And we'll measure the angle. We'll measure the angle here on the level of flexion that he has here. So we'll check that both passive and actively. Okay, so I'll have the patient try and straighten it out for us now. And try to hyperextend it, good, and then try to flex it for us also. Good, and then you can relax your knee back down again. And we'll again pair that to the other leg. After range of motion, we'll test his strength. In particular injuries of the knee, such as a quad tendon injury, the patient will have difficulty doing a straight leg raise. So we'll ask this patient to bring his leg straight up, about 6 to 12 inches. Bring it up a little bit higher. Perfect, then I'll have him resist. Keep pushing up for me. Good, and relax. So that will test his strength with regards to the quad tendon. Now we're going to test his strength with regards to the patellar tendon. And the way we test that is with knee extension. So I'll bend his knee up. And then I'll ask the patient to try to straighten the leg out for me against resistance. Good, he does very well there. So that gets both our quad muscle as well as testing the patella tendon. And then lastly, we're going to test knee flexion strength. And we can test that in this position while he's supine, or we can test him in the prone position. What we'll have him do in this position is try and push his heel back against his butt against me here. And he resists very well. Good. So we tested his strength. So far we've done inspection, we've done palpation, we've done his strength testing. Now we can move on to the special tests. We've already alluded to the patella with the Patella Grind and the Patella Apprehension. And now we're going to move on to the ligaments. There's 4 major ligaments within the knee. 2 that crisscross deep in the knee, called the anterior cruciate ligament and the posterior cruciate ligament. Then you also have ligaments on the side. One is called the medial collateral ligament, or MCL. And one on the lateral side called the lateral collateral ligament, or LCL. So we'll test those. The tests that we'll check for the ACL are 2 tests. One is called the Lachman's test, and the other one is called the Anterior Drawer. So first we'll test for the Lachman's test. I'll come over to the side of the patient, and what we typically like to do is stabilize the thigh, as well as come just below the tibial tubercle on the tibia. And I'll just gently externally rotate the leg to get the hamstring muscle to relax and get the patient relaxed. And then in 15 degrees of flexion of the knee, I'll stabilize the thigh, and I'll apply a force upwards on the tibia. And I'll look to see how much movement or translation there is between the tibia and the femur. Generally, the textbook answer says you're feeling for a soft endpoint when there's an ACL injury versus a very ropey end or tug. So in this patient, we'll get him to relax, and then we'll apply a force. Now, many mistakes that people make is that they apply a force that goes directly up this direction. But you want to make sure your force is perpendicular to the tibia. So if you have the knee flexed in 15 degrees, your force will be this direction, not this direction, okay? So that tests for the Lachmans. While we have him in this position, we can test both the MCL and the LCL. And we'll test that in 2 positions. I'll take my hand and come underneath the knee here, and I'll kind of hold his ankle. One of the techniques I like to do is I like to just gently squeeze the skin, which makes the skin a little taut. And I'll again keep them slightly flexed between 15 and 30 degrees. And I'll apply a Valgus Force to see if there's any movement or opening of the ligament in this area here. I use the palm of my hand here to apply that force on the lateral side of the knee while I'm taking the ankle and gently pulling it laterally. So we're doing this force like this. Now we'll come around and we'll do the same thing on the LCL. I'll take my hand on the inner side of the knee here, my hand over here on the lateral side, and I'll be applying an opposite force, pushing laterally on the knee, applying a force, looking for any laxity or movement. You can also ask the patient if they have discomfort when you do this maneuver, as it could be a low-grade sprain rather than a high-grade sprain which has no laxity. Now, we'll test both the ACL and PCL in a different position by bringing the knee up to 90 degrees. You'll like to stabilize the foot while you do this position because you will be pulling and pushing on the tibia in relation to the femur. Naturally speaking, the best way to do that would be to make sure there are no problems with the patient's foot and just kind of gently sit on them, coming underneath, trying to get the hamstring to relax once again, and you'll be grabbing the front of the tibia with your thumbs just below the joint line and pulling on the tibia. So you're applying this force to test the ACL. Conversely, to test the PCL, you'll be applying a backwards force. So same thing, you'll take your thumbs just at the joint line or just below it, and you'll be applying a posterior force. And again, checking for movement or translation. Additionally, when you're testing the PCL, you'll want to assess where the tibial plateau is in relation to the femoral condyle. In the majority of patients, the femoral condyle will sit further back in relation to the tibial tubercle. So the tibial tubercle, the tibial plateau, my fault, the tibial plateau is usually more proud or sticks out further than the femoral condyle. If that is flush or the tibial plateau is further beyond that or behind it, then you have an injury to the PCL. Lastly, we're going to test for the cartilage. And the best way we test that is, again, joint line tenderness, which we checked laterally as well as medially. The second test we'll check for the meniscus is a test called the McMurray's test. And you do it different based on the meniscus you're testing. If you're testing the medial meniscus, which we'll show now, I'll walk over to the side of the patient. And you'll get a hold of the joint line. You'll place your fingers along the joint line while picking up the foot and cupping the heel. While cupping the heel, you'll bend the knee up and you will apply an external rotation on the leg while applying a valgus force and seeing if this will elicit pain while you extend the knee out. This is testing the medial meniscus. If that causes pain, or you feel or hear a audible or palpable click or clunk, that's usually worrisome for a meniscus tear. To test the lateral side of the knee, we'll do very similar fashion except the opposite direction. Again, I'll grab the joint line, I'll cup the heel, I'll apply flexion to the knee, internally rotate the leg while applying a Varus force and bringing the knee into full extension. And then we'll set it back down for the patient. This is a general knee exam that you want to check on most of your patients. Now after you're done with this, you can also have the patient stand up. You can also test the standing component in the beginning, which would probably be the most ideal situation. And what you'll have the patient do is have about shoulder width stance apart, pointing his toes straight ahead. And you'll have the patient look straight ahead also. you look at a few things. One, the relationship of the feet and the arches. You want to make sure the patient has symmetric arches. If there are any areas of flat feet, if there's any turning into the foot or pronation, if there's any bowing of the knee. You'll also check to see the direction where the kneecap points. In his case, you can see this patient, his kneecap kind of points a little across his knees on both sides. Generally speaking, the patient will want to walk straight with the kneecaps pointing straight ahead, so this patient probably opens his feet up into external rotation, which is a more comfortable position for him. This is important for assessing kneecap pain a lot of the times. Now we'll have the patient turn 180 degrees, and we'll also look at the leg from behind. Again, if you could point your feet straight ahead, please. And what we're going to look for is something called pronation. The simple rule to look for pronation is the 3-toe rule. So looking at this left leg, when you're looking from behind, if you can see the 3 lateral toes popping out from your direct view, then usually they have pronation or the foot is rolling in. That is something we want to correct if we're dealing with kneecap pain issues. Again, we'll also just look at symmetry, calf size on right to left, and then we'll also check and assess the pelvis and see if the pelvis appears to be symmetric in height. So you'll walk up, find the iliac crest, and you'll just look to see if the left and right are about the same height.